One of the most challenging aspects of managing the subacute combined degeneration is interpreting the recovery after vitamin B12 replacement therapy. Imagine this scenario: your patient is walking better, their numbness is improving, and their balance is returning, but the follow up MRI still shows persistent spinal cord abnormalities. What should you do? Stop the treatment, reconsider the diagnosis, or simply wait? The answer lies in understanding that clinical recovery and radiological recovery do not occur at the same place. Following the cobalamin replacement therapy, neurological improvement often begins within weeks to a few months. Patients may notice better gait stability, reduced paresthesis, and improvement in vibration and position sense. However, MRI changes frequently lag behind the clinical improvement. Persistent T2 hyperintensities within the posterior columns do not indicate treatment failure or alternative diagnosis. Instead, they may represent ongoing remyelination and healing of previously damaged spinal cord pathways. This concept is known as reading the lag, recognizing the patient can improve clinically while imaging findings resolve more slowly over time. Understanding this timeline is essential to avoid unnecessary investigations, inappropriate treatment changes, or mislabeling a recovering patient with another neurological disorder. In this session, we will explore how the spinal cord heals after vitamin B12 therapy, when repeat imaging is truly necessary, and how to distinguish normal recovery patterns from signs of persistent disease. Let's learn how to monitor spinal cord recovery with confidence. The recovery case, Ranjan's rapid reversal. Let's look at a real world example demonstrating how early recognition and prompt vitamin B12 replacement can dramatically reverse the subacute combined degeneration. Meet Ranjan Pillai, a 57-year-old strict vegetarian for over 25 years, who presented with progressive sensory ataxia worsening over 6 months. At baseline, his investigations painted a concerning picture. His vitamin B12 level was only 112 pg per ml, indicating severe deficiency, while methylmalonic acid or MMA was critically elevated at 1240 nmol per liter, confirming the significant metabolic dysfunction. Clinically, Rajan had a strongly positive Romberg test, losing balance between the eyes when they were closed. Vibration sense was absent below the knees, reflecting severe posterior column involvement. His gait impairment had progressed to the point that he was unable to walk without assistance. MRI of the cervical spine demonstrated that the classic inverted V sign extending from C3 to C7, confirming posterior column demyelination consistent with subacute combined degeneration. Treatment was initiated immediately using hydroxocobalamin 1000 micrograms IM, administered daily for 7 days, weekly for 4 weeks, and then continued monthly as maintenance therapy. The result after 6 months were remarkable. His vitamin B12 increased to 655, reaching the therapeutic range, and MMA normalized to 180 nmol per liter, indicating the biochemical recovery. Most importantly, his neurological examination improved significantly. The Romberg sign became negative, vibration sensation returned up to the ankles, and he regained the ability to walk independently and resume the activities such as driving. Follow-up MRI showed marked reduction of the spinal cord signal abnormalities, reflecting ongoing remyelination and structural recovery. This case highlights a crucial message. Subacute combined degeneration is potentially reversible when recognized early and treated promptly. Delayed diagnosis may lead to permanent neurological deficits, but timely vitamin B12 replacement can restore both function and the quality of life. The sooner you identify the deficiency, the greater the chance of a complete recovery. How the cord actually heals. The four phases of reversal. One of the most important concepts in subacute combined degeneration is understanding that the neurological recovery does not happen overnight. The spinal cord heals in predictable stages after vitamin B12 replacement. Phase 1, the biochemical repair, day 1 to 14. The first changes occur at the cellular level. Once vitamin B12 enters the cell, the key metabolic pathways restart. Methionine synthase becomes active again, reducing the toxic metabolites such as methylmalonic acid and homocysteine. At this stage, patients may not feel dramatically better yet, but the biological foundation for recovery is being established. Phase 2. Axonal stabilization, week 2 to 6. As metabolic function normalizes, damaged nerve fibers become more stable. Electrical conduction improves and axonal firing begins to normalize. This is often the stage where the patients first notice clinical improvement. Tingling may decrease, balance starts improving, and walking becomes slightly more confident. Phase 3. Myelin Resheathing, week 6 to 16. The next phase involves the actual structural repair. New myelin begins to form around the damaged nerve fibers, restoring the efficient signal transmission. Clinically, perception and vibration sense gradually improves. On MRI, the classic T2 hyperintensity starts fading as inflammation and excess water content decreases. Phase 4. Structural consolidation. Month 3 to 12. In the final phase, remyelination becomes more complete and stable. Myelin layers compact and mature, allowing near normal nerve conduction. MRI abnormalities continue to regress, and many patients achieve substantial or even complete neurological recovery if treatment was started early. The golden rule, why the MRI lies to you early on. A key lesson in monitoring recovery is understanding the physiological lag between the clinical improvement and MRI improvement. After vitamin B12 therapy, patients often begin walking better and regaining sensation within a few weeks because nerve conduction improves rapidly. However, MRI changes resolve much more slowly. The T2 signal remains visible because water is still trapped within the damaged myelin. Only after structural remyelination, the myelin compaction does the MRI begin to normalize. This creates the physiological lag where the patient is clinically improving but the MRI still looks abnormal. The golden rule, clinical improvement almost always comes from MRI normalization, often by 4 to 8 weeks or more. So, never stop the treatment simply because a follow up MRI still shows signal changes. If the patient is improving, the spinal cord is healing. Treat the patient, not the scan. Now, let's see what recovery looks like on MRI over time after successful vitamin B12 replacement. At week 0, the classic inverted V sign is clearly visible. The posterior columns appear brightly hyperintense on T2 weighted imaging, often extending from C3 to C7, reflecting active demyelination and edema. By week 6 to 8, the signal begins to dim. The hyperintensity becomes less bright and the affected areas start to shorten. This is often the first radiological sign that healing has begun. At around month 3, the inverted V sign continues to fade. The abnormal signal becomes much less conspicuous, and the signal intensity gradually approaches that of a normal spine cord tissue. By month 6, many patients show near complete radiological resolution. The cord appears essentially normal with disappearance of hyperintense signal and no evidence of significant atrophy when treatment was started early. The key point is that MRI recovery follows a predictable sequence: full V, dimming V, fading V, and cleared V. Remember, radiological improvement lags behind the clinical improvement. Patients may already be walking better and regaining the sensation long before the MRI completely normalizes. The fading V sign is visual proof that remyelination and spinal cord recovery are taking place. When monitoring recovery is subacute combined degeneration, choosing the correct MRI sequences is essential. Sagittal T2 imaging provides an overview of the length and the extent of the spinal cord involvement and helps track signal shortening over time. Axial T2 images, especially from C3 to C7, are crucial for visualizing the classic inverted V sign and assessing whether it is shrinking or disappearing during the recovery. SCIR sequences are highly sensitive to edema and inflammation and often show improvement earlier than standard T2 imaging. Finally, T1 sagittal images help assess the spinal cord atrophy. Preservation of cord size is a favorable prognostic sign and suggests a better chance of neurological recovery. Whenever possible, a 3 Tesla MRI scanner is preferred because it can detect subtle changes more accurately than 1.5 Tesla systems. In summary, serial MRI helps document healing, but remember, the patient's clinical improvement remains the most important indicator of recovery. Biochemical monitoring, quantifying the reversal. Clinical improvement is important, but laboratory markers help us objectively measure the recovery after vitamin B12 replacement. Three key biomarkers should be monitored: serum vitamin B12, methylmalonic acid or MMA, and homocysteine. The goal is to achieve a vitamin B12 level above 400 pg per ml and MMA level below 270 nmol per liter and a homocysteine level below 15 micromoles per liter. Among these biomarkers, MMA is the most valuable indicator of tissue level recovery. Unlike serum B12, which can rise quickly after supplementation, MMA reflects whether vitamin B12 is actually functioning inside the cells and restoring normal metabolism. At the baseline, patients often have markedly elevated MMA levels after treatment begins. Serum B12 usually reaches the therapeutic levels within the first 2 weeks, while homocysteine starts trending downward. By week 4 to 6, MMA falls dramatically and hematological abnormalities such as macrocytosis begin to resolve. Over the next 2 to 3 months, MMA approaches the normal range, confirming successful metabolic recovery and adequate intracellular vitamin B12 activity. A critical warning: if MMA remains elevated beyond 8 weeks despite adequate vitamin B12 therapy, clinicians should reconsider the diagnosis. Alternative causes such as copper deficiency, multiple sclerosis, neurocephalus, or underlying malabsorption should be investigated. So, falling MMA is one of the strongest biochemical signs that treatment is working and the nervous system is recovering. One of the most important determinants of outcome in subacute combined degeneration is how quickly treatment is started. There is a critical window during which neurological damage remains reversible. On the left side of the predictors of complete recovery, patients treated with first 3 months of symptom onset have the highest chance of regaining their normal neurological function. Younger patients generally recover better because their remyelination capacity is greater. Rapid normalization of MMA, usually within 4 weeks, is another positive sign. The absence of the spinal cord atrophy or the baseline MRI and early shortening of the abnormal MRI signal also indicates a favorable prognosis. In the center, we see the difference between a remyelinated spinal cord and one affected by reactive gliosis. Remyelination represents true healing and restoration of function. Reactive gliosis, however, is a form of permanent scarring that develops when treatment is delayed. On the right are the predictors of partial or stalled recovery. Delayed treatment beyond 6 months, persistent MMA elevation, spinal cord atrophy on MRI, continued neurological decline despite therapy, and persistent MRI abnormalities at 6 months all suggest a poorer income. The key message is simple. The earlier vitamin B12 deficiency is recognized and treated, the greater the chance of complete neurological recovery. Time is caught, every month of delay increases the risk of irreversible spinal cord damage. Even with the correct diagnosis, monitoring mistakes can delay recovery and worsen the outcomes. 5 common errors should be avoided. First, never stop vitamin B12 therapy just because the MRI looks normal. Many patients require a lifelong replacement. Second, don't declare treatment failure at week 8 based on the MRI findings. Clinical recovery often occurs before the MRI normalization. Third, always obtain a baseline MRI. Without it, follow up scans cannot be accurately compared. Fourth, never ignore clinical worsening just because the MRI appears improved. The patient's examination is more important than imaging alone. And finally, remember that 3 Tesla MRI is more sensitive than 1.5 Tesla MRI for detecting subtle residual lesions. The key takeaway is that monitor the patient, the biomarkers, and the MRI together. Never rely on a single parameter alone. In many settings, regular MRI monitoring is difficult due to limited availability, high costs, and poor long term follow up. However, effective monitoring is still possible. At every visit, perform rhombus testing and vibration sense assessment. These simple bedside tests are sensitive indicators of neurological recovery. For biochemical monitoring, check MMA and homocysteine levels at 4 and 8 weeks whenever available. They provide evidence of tissue level response to the vitamin B12 therapy. To reduce the cost, obtain an MRI at baseline and again around 6 months, avoiding unnecessary intermediate scans. Most importantly, ensure adherence to long term hydroxocobalamin therapy. Patient education and regular reminders are essential to prevent the relapse. Remember, in source limited settings, careful clinical examination often provides more value than the frequent imaging. This timeline summarizes Rajan's complete recovery journey after vitamin B12 replacement therapy. On day 0, he presented with vitamin B12 deficiency, sensory ataxia, and the classic inverted V sign on MRI. Treatment with intramuscular hydroxocobalamin was started immediately. By week 2, biochemical improvement appeared first, with falling MMA levels and increased energy. Between weeks 4 and 6, gauge stability improved and rhombus positively began to decrease. At week 8, the first MRI changes became visible, confirming the radiological recovery following the clinical recovery. By month 3, Rajan was walking independently and MRI abnormalities continued to fade. At month 6, biochemical markers normalized and MRI showed near complete resolution. Finally, at month 12, he achieved sustained recovery with normal function and continued lifelong maintenance therapy. Subacute combined degeneration, early diagnosis, and prompt vitamin B12 replacement can transform the disability into the recovery. Let's finish with some high yield examples. A patient with subacute combined degeneration shows improved gait and falling MMA levels after 8 weeks of treatment, but the MRI still shows posterior column hyperintensity. What should you do? The correct answer is continue the current therapy. MRI recovery lags behind the clinical and the biochemical improvement by several weeks. Do not stop or change the treatment solely because the MRI remains abnormal. Remember, these key exam points, the early sign of the improvement is increased energy and reduced fatigue. STIR sequences often normalize before T2 weighted MRI changes. Caught atrophy on baseline imaging predicts the poorer recovery. And one major red flag, if new lesions appear on serial MRI, think of multiple sclerosis rather than vitamin B12 deficiency. For exams and clinical practice, remember this simple rule: treat the patient, not just the MRI. Thank you for watching this presentation on monitoring the spinal cord recovery after vitamin B12 therapy in subacute combined degeneration. The key message is simple: recognize the disease early, start vitamin B12 replacement promptly, and understand that clinical recovery often comes before the MRI normalization. Remember the three essentials: monitor the patient, track the biochemical markers, and interpret MRI changes in the correct timeline. Early diagnosis can prevent permanent neurological disability and restore the quality of life. If you found this presentation helpful, please like, share, and subscribe for more high yield medical content. Thank you and see you in the next session.